Hello, everyone. I'm Kyrillus Shohdy, an investigator in advanced immune and cell therapy team at the Christie in UK. And I'm pleased to present this talk on the adoptive cell therapy for solid malignancies, a Christie experience. So, as we all know, the immune system usually could mount anti-cancer immune response against cancer cells. And this usually starts with an antigen-presenting cell like dendritic cells that can actually recognize some of the cancer antigens. And the antigen-presenting cells then go and present the antigen to the T cells through the major histocompatibility complex molecule, what we call MHC or HLA. And the T cell now become activated, and there's a lot of mediators and co-stimulatory or co-inhibitory signaling involved in this process. But at some point, the activated T cell, what we call cytotoxic T cell, can able to infiltrate the tumor microenvironment and recognize the cancer cells and kill them. And recently, we tried to leverage this anti-cancer immune response in various approaches, like initially using a vaccine to boost the recognition process by antigen-presenting cells, try to interfere with the co-inhibitory signaling from CTLA-4, or sometimes the co-inhibitory signaling from PD-1 or PD-L1, or use one of these stimulatory cytokines like interleukin-2. And most recently, we are actually trying to use the active cytotoxic T lymphocyte itself as a therapy, what we call adoptive cell therapy. So the key attractions of adoptive cell therapy that the genetic modifications of T cells actually allow to target the tumor-associated antigens, and this actually can enhance immune cell reactivity against tumor. And we still have a strong power to ex vivo stimulation and expansion of the tumor-reactive T cells to overcome the impediments of T cell function known to happen in the tumor immunosuppressive microenvironment. Also, the ability to manipulate the patient tumor microenvironment prior to the transfer of ex vivo expanded T cells to augment the adoptive cell therapy efficacy. So, for example, giving high-dose chemotherapies that can get rid of all the bad immune cells, then we can transfer our good immune cells back. So, and this lead to the innovation of using T cell therapy for solid tumors. And basically, the key principles of this modality of treatment is to collect T cells from the patients, either to manipulate it genetically or not, and then we can expand it, and then we could do some safety and efficacy analysis to make sure that we have the really effective T cells, and then we can make an infusion of these cells and give it back to the patients. And because we know that the patients with advanced cancer usually have immunosuppressive immune microenvironment, so we tend to give him like high-dose chemotherapy, conditioning chemotherapy to get rid of all these immunosuppressive microenvironment and give our T cell therapy on really clean background. So the current approaches for T cell adoptive cell therapy include either to use just the natural T cells using the natural mechanisms that I just mentioned, which is basically T cell receptors that are able to recognize an antigen presented through the MHC molecules. And all what we can do is just collecting T cells either from the blood or from the tumor through the tumor infiltrating lymphocytes, and we just expand it ex vivo and then transfer it back, adding some stimulant like interleukin-2 or something. The other way around is actually we can manipulate the T cells. We can genetically engineer or genetically modify the T cells to really have more affinity or more specificity to target specific antigen on the surface of the cancer cells. And currently there is two approaches to do that. The first approach was just what we called chimeric antibody receptors, the CAR-T cells. And the CAR-T cells, as we can see on this right side of this diagram, it is just an antibody that able to identify an antigen on the surface of the cancer cells. And this antibody is actually attached with signaling molecule, which in this case, the most common part in the in the T cell receptor, which is the CD3 zeta. And the signaling is enough to cause the signal go through the cell, and the T cell can actually mount its anti-tumor effect. The other way around is to basically modify the T cell receptor through making it have higher affinity and enhance its binding to antigen presented by the MHC molecules. And this approach, sometimes we call just T cell receptor T therapy. So I will quickly give some notes on these three types, the TEL, the TCR, the CAR, and give you some experience of cases we are treating at the Christie. So the TEL treatment is very straightforward. We just collect T cells from fresh biopsy. So the first thing to do is surgery or biopsy, excisional biopsy, to remove a really large chunk of the tumor, maybe 2 centimeters or more. And the classic patients who we know that this will be very effective is melanoma. And then we can cut the tumor into very small pieces, culture them with interleukin-2, allow space for the T cells to expand, to grow, and then we can actually, through some chemical manipulations, we can analyze the T cells and only isolate the really highly reactive ones and make an infusion that we can actually give back to the patient. Because as we know, patients with advanced cancer usually have this immunosuppressive microenvironment. So it's better to get rid of all these immune cells through high-dose chemotherapy, something like cyclophosphamide and fludarabine. So before giving the patient the ex vivo expanded TEL treatment, we tend to give them like high-dose chemotherapy for 3 to 5 days, then we transfuse the cells. And that's it. It's one-time treatment. And usually we can add intravenous interleukin-2 to the patient to allow some support for this T cells to be persistent for some time in the circulation, to allow them to infiltrate the tumor and make some reactivity. And this is a patient with melanoma, metastatic to mediastinal lymph nodes, that received one of these TEL therapy at Christie. And we can see after maybe 3 months, he entered a near CR response. So the other approach for adoptive cell therapy is just to really genetically modify the T cell. And this can be either through chimeric receptor or the endogenous receptor that is manipulated to have higher affinity. So regarding to the chimeric antibody receptor, what we call CAR T cell therapy, this is very simple. On our left side, we can see the normal T cell receptor, which is formed of external part that have alpha and beta chains, the variable and constant regions, and some signaling domains inside, and supported with co-stimulatory domains that help in making the signal really effective. And the signal is actually started when this T cell receptor attached to MHC epitope complex, which is basically an MHC with a protein on its surface or an antigen. So we use the same principles in developing chimeric receptor, which is depend only on just an antibody, very classic antibodies that can recognize specific antigen on the surface of the immune cells. And this antibody is actually attached to intracellular signaling domain, which in this case was CD3 zeta domain only. So we just take this signaling domain from the naturally occurring T-cell receptor, and we instead of making all this alpha beta chain variable regions, we just make a conventional antibody segment that can actually attach to a cell surface antigen. And currently there is development for second generation CAR T cells and third generation CAR T cells, and all what we need is actually adding more co-stimulatory regions that help in stimulation of the T cell. So I think the key question now is to think about the perfect tumor antigens that we can make CAR T cell actually attack or bind to or target. So usually the classic examples for targetable tumor antigens, those who are overexpressed on cancer compared to normal tissue, we have HER2, CA, MART1, or sometimes you have a protein or antigens that is expressed on cancer, and you might find it in normal tissue, but the normal tissue is basically non-essential normal tissue, so you can easily sacrifice it, like CD19 and thyroglobulin. Or sometimes the antigen is only expressed on cancer cells, and this is basically the perfect antigens that you can target with CAR. And we have this group of antigens called cancer testis antigens that usually uniquely presented on cancer cells. Viral antigens, which is basically formed from integration of the viral genome in the cancer cells. Some tumor stromal component actually can be targeted as antigens. We know that cancer cells themselves accumulate mutations, and these mutations at some point can produce abnormal proteins, mutagenic proteins, and we usually call them neoantigens. And neoantigen is really attractive target, but the problem is that it is highly personalized. So you have to sequence the tumor of the patients to make sure that there's an abnormal protein, and to make sure that this protein is actually can elicit an immune reaction, because not all abnormally expressed proteins are immunogenic and considered neoantigenic. So currently, maybe the only successful story for CAR T cell is targeting CD19. CD19 actually is really nice example of cancer antigen, because it's expressed maybe almost on the B cell malignancies, on CLL, small lymphocytic lymphoma, follicular lymphoma, diffuse large B-cell lymphoma, and acute lymphoblastic leukemia. And it is found mainly on B cells, and usually B cells, the turnover of them is very high, and we can sacrifice a couple of B cells, the normal B cells. It is not on the stem cells of the blood, so will not cause any problems of extreme myelosuppressions, and not expressed elsewhere in like healthy tissues. So it's perfect target to get to actually tailor a CAR T cells that can actually recognize the CD19 bearing cell and kill them. And a couple of years ago, a lot of phase 1 trials started that try to target CD19 cancer cells. And usually these studies start with a patient with advanced malignancies that is CD19 positive, like lymphoma and diffuse large B-cell lymphoma and follicular lymphomas. So we tend to collect the T cells, autologous T cells from them, and we genetically modified the T cells by adding a virus, a retroviral vector that able to express the chimeric receptor, which is basically an antibody against CD19 with a signaling domain. And then at some point, we run some safety and efficacy analysis in vitro to make sure that these genetically modified cells are actually reactive and doesn't have any off-targets effects. And before we transfuse the cells back to the patients, we want to make sure that all the bad immune cells in the circulation are removed. So usually we give high-dose chemotherapy conventionally using fludarabine and cyclophosphamide for a couple of days, and then we can transfuse back the genetically modified chimeric T cells to the patients, plus or minus interleukin-2. So, and this is one of the early patients who received CAR T cells against CD19 in CREST-T. This patient actually was marginal zone lymphoma, and we can see here that there is objective response at week 26 post-infusion. And actually, we currently completed a long-term follow-up of one of the earliest CD19 clinical trials, and our current objective response rate is really interesting, reaching to 75%. And here is examples of the patient who responded in our study, and this data is pending publication now. And also, we have some long-term survival data from CD19 CAR-T trial that is published a couple of weeks ago in New England Journal of Medicine. And the interesting thing we can see that the progression-free survival in patients with diffuse large B-cell lymphoma is actually 31%. And in follicular lymphoma, we can see it is 43%. And this actually recapitulates the long tail principles that we observed initially and using immune checkpoint inhibitor in melanoma, and proving the evidence that immune therapy is actually very effective in subset of patients, but it leads to durable responses. So, and currently there's a couple of CAR T cell that is approved in US and in UK and in Europe. And here's an example of them either targeting the CD19 and most recently, actually, another targeting come into practice, which is BCMA and multiple myeloma. And as you can see, this drug is really expensive because the genetic modification and the process is really difficult. So the cost here might reach to $400,000. So the CAR T cell still have some toxicities that we need to put in our mind. And some of these toxicities is related to the conditioning therapies, the fludarabine and cyclophosphamide, which can cause neutropenia, neurotoxicity. Sometimes we use interleukin-2, which is associated with a specific profile of toxicity. The T cell themselves actually can have some toxicity, and their toxicity usually we classify it according how they act. Sometimes some toxicity because they act very aggressively to their targets on the tumor. So this actually lead to tumor lysis syndrome in lymphomas and in releasing a lot of cytokines, leading to cytokine release syndrome. Sometimes they attack their target, but not on the tumor, on other healthy tissues, like in brain tissue, leading to non-tumor tissue damage. Sometimes they attack other targets that we are not aware of, not on the tumor, lead to non-specific reactions, lead to activation of specific immune cells. Also, there is minimal risk of genotoxicity because at the end of the day, these genetically modified cells contain retroviral vector, and there's some risk of insertional oncogenesis from this virus, but it hasn't been documented clinically yet. So, and I think the most common side effect we see in treating those patients is the cytokine release syndrome, which is usually occur either early and after cell infusion or maybe late in the second week of cell infusion. And usually there is a combination of cytokines that increase, including interleukin-2, interleukin-6, and usually the treatment sometimes is just supportive if it is low grade, and if it's high grade, sometimes we need to give tocilizumab and steroids. So However, there is a couple of challenges in using the CAR-T cell or the adoptive cell therapy in solid tumors. First, the key challenge is actually you need the CAR-T cells actually to infiltrate the circulation and reach to the tumor, what we call the trafficking, and to recognize the tumor area, what we call homing, which is maybe very difficult in solid tumors in comparison to hematological malignancies. The other way, because the solid tumors tend to have this really immunosuppressive microenvironment, and when you add an extra cell, there's no guarantee that the cell can actually expand and persist in the tumor microenvironment, in contrary to hematological malignancy, which is basically in the blood, and the expansion and persistence of T cells in the blood is more easier than in tissue. And last thing is like durable survival, because to achieve long-term response, you need this T cells actually to survive for maybe years in the tumor to keep it under control. So there's a lot of challenges, as we can see, of using the principle of CAR-T cell in solid tumors: the trafficking, the tumor recognition, the expansion and persistence, and the durable survival. All these factors make the CAR-T cell not attractive option in solid tumors. And actually, we have done before at Christie a trial using CAR-T cells to target CEA on the surface of solid malignancies. And as we expected, the T cells actually weren't able to infiltrate and stay in the tumor tissue, and they didn't mount any significant anti-tumor responses. And here, as we can see, this is immunohistochemistry and the qPCR testing for the T cells, the engineered T cells. And as we can see in most of the tumor samples, the existence or the abundance of the CEA targeting CAR-T cells is low. And we didn't see any responses in this study. That's why we start to think in another approach, which is using the T cell receptor itself, not a chimeric antigen, because the problem with the chimeric antibody receptor that the chimeric is actually attacking the surface antigen directly without the need for antigen presentation cells, and this make the target antigen has to be highly expressed and accessible, for example, in the circulation, like the case with hematological malignancies. But in solid tumors, there is a lot of things that the T cells has to do, like trafficking, homing, and high affinity, which is lacking in the CAR T cell. So the perfect approach may be to use the TCR-T cell instead of CAR T cell. And here's this nice diagram showing the distinct features between the CAR T cell and TCR-T cell. The CAR T cell usually limited only to extracellular targets, which are really few targets, and it depends on the chimeric antigen receptor that does not necessitate any antigen presentation, so there's no need to MHC molecules or something like that. But the TCR is actually can target any protein, either intracellular or extracellular, because at the end of the day, the protein is actually processed and presented to the surface through the MHC molecules. And here you can make full benefit from the T cell receptor, which has higher affinity to attach to MHC molecules. So we actually started to think how to use like the T cell receptor rather than using CAR T cell. And at Christie, we developed a trial for patients with sarcoma. So our principle was to identify cancer antigens that's highly expressed in sarcoma, so that we use the NY-ESO1. This is one of the cancer testis antigens. And the good thing is that this antigen is uniquely expressed in cancer because it's cancer testis antigen and not found much on any healthy tissues. So it's perfect candidate. The second point in our experimental workflow is actually to collect autologous CD8 positive T cells from the patient through a process called apheresis. And then we come to the really innovative process, which is T cell manufacturing. And we were able to manufacture the autologous T cells through adding a lentiviral vector that can actually express affinity enhanced NY-ESO antigen specific TCR. And here in this diagram, we can see the expressed TCR, and how we can see that this completely different than the CAR, and it is fully formed T cell receptors that have like all the co-stimulatory and main signaling domains, and it depends on attaching to the MHC, which increase the affinity remarkably. So even if this antigen, which is NY-ESO, even if it is low expressed or not highly accessible, we can still the T cells can still recognize it through the antigen presentation system. And then, of course, the patients underwent lymphodepletion with fludarabine and cyclophosphamide because we need to get rid of all the immunosuppressive microenvironment there for a couple of days. So sometimes they require to be hospitalized actually. And then we do like the TCR-T cell infusion, admit the patient for maybe up to 2 weeks. A lot of them develop acute toxicity, as we mentioned, like cytokinery syndrome, and patients usually have to stay around the hospital so that if they develop anything serious, they can get an access to care immediately. And then we usually keep long-term management because it's one-time treatment, and then we do the regular scans and regular follow-up. And actually, this approach, we could actually collect T cells and successfully manufacturing them with this way in 2 patients so far. And 2 patients have, one of them have synovial sarcoma, which we can see here, it's reduced significantly. There was a little bit of interval progression. We cannot tell if it's pseudo progression or not, but the patients at the end responded. The another patient was diagnosed with myxoid liposarcoma, and in her last scan, she had really heading toward tumor response with around 40% reduction in the tumor size, which is really significant in patients heavily pretreated for their sarcoma. And we are still going ahead with this trial to recruit some other patients before we can publish the final data. So I think this is the end. Thank you.